Medurstand Understanding Medicine.
I'm Professor Aziz Rehman, President-elect Pakistan Society of Internal Medicine. And today we're going to talk about oral semaglutide. And this is a relatively new development. And we know semaglutide for quite some time, and it is available in the form of injection. But the recent development is the same drug is available in oral form also. And these are the learning objectives of my presentation: understanding the SNAC technology. Subsequent slides I will explain what does it mean. With this, it became possible to administer a peptide orally without getting destroyed by the stomach. And then we will also briefly talk about the pharmacokinetics and pharmacodynamics of this drug and dosing. Then summarize efficacy from various trials. There are 3 series of trials: Pioneer from 1 to 10, Oasis, and Soul trials. And compare oral versus injectable semaglutide and how do they compare with each other as far as efficacy is concerned on glucose control and on weight control, and discuss various interactions and administration of this drug. So first of all, the SNAC technology, semaglutide is a peptide, and peptide is digested in the stomach and the intestine because it is basically a small protein molecule. So with this SNAC technology, this is what SNAC stands for. I think you can remember from the word snack, which we are very familiar, but not H. So SNAC technology is which mixed with semaglutide, and that way it enables its absorption. So there are 4 mechanisms actually. A tablet is taken, whole tablet, which contains semaglutide as well as SNAC. And this SNAC, what that does is it increases pH in the stomach, and because of that, less acid and less chances of peptide getting destroyed. And also less acid also means that the pepsin will not be activated, so proteolytic activity will also be reduced. Plus, it temporarily increases the permeability of the gastric cells, stomach cells, so that the peptide is absorbed. Once it is absorbed, it will be just like a normal semaglutide. So I think this whole new technology made the absorption of this peptide, semaglutide, possible, and it also prevented its destruction from stomach acid and stomach enzymes. It's, the pharmacodynamics. What does semaglutide do? It has got multiple action. It has got effect on beta cells, and it stimulates insulin production as well as insulin release. It suppresses glucagon because that is also an abnormal phenomenon in type 2 diabetes. And it delays gastric emptying so that less food goes to the duodenum and less is digested, and you feel full for later, for a long time. And it also reduces the appetite. So all these 4 effects, which are well known with injectable semaglutide, are also applicable on oral semaglutide. But its bioavailability is very low. You remember, in the injection, our starting dose is 0.25 milligram subcutaneous. But here the starting dose is 3 milligram because only 1%, and that also only if you take it with a specific method, which I'm going to explain. So 1% or less is absorbed. You have to take 3 milligram every day for 7 days to get equivalent to 0.25 milligram once a week. So there is very little bioavailability, but that's not a problem. Whatever is bioavailable, that is functional. So it is that you get T max in 3 hours, up to 3 hours, and the effect lasts for 1 week, just like injectable semaglutide. There is a specific method of taking it. I think this is extremely important. You have to take it, number 1, on empty stomach in the morning, because that is the only time when our stomach is truly empty. Don't eat or drink anything before you take this drug. and it is to be taken with small amount of water, just a sip. I always emphasize it should be just a sip, just enough to take the tablet to your stomach, and it should be water, no other liquid, because studies are with water, no juice, no milk, no nothing, just simple water, less than 120 ml, and swallow the tablet whole, because if you chew it or you make it two halves, then this snack technology will be disturbed. So everything in the morning with water, just a sip, and then for half an hour at least, don't eat or drink anything. I recommend 1 hour, because studies have shown that in 30 minutes there is reasonable absorption, but in 60 minutes there is some more absorption. So to have the best effect of this drug, I think it is best to wait for 60 minutes after taking it. So the starting dose is 3 milligram once a day in the morning, and you may not expect any glucose lowering effect with 3 milligram. Just like injectable semaglutide, we start with 0.25 milligram. We normally do not expect any effect with that small dose. But in some individuals with 0.25 milligram, you also get the effects, sometimes bad effects, sometimes good effects. Similarly, with 3 milligram also, I think some patient might develop some nausea, vomiting, or loss of appetite, and some glucose lowering effect also. But standard practice is the 3 milligram is given once a day for 1 month, just to see how this drug is tolerated by the patient. And the next month we move on to 7 milligram, like in injectable semaglutide we move to 0.5 milligram. Many patients would have desirable effect with 0.5 milligram of injectable and 7 milligram of oral. If patient tolerates 7 milligram well, glucose lowering effect is also acceptable, then we may not proceed further. Patient may be asked to continue 7 milligram. And of course, after 3 months, patient has been taking 7 milligram, then we do his HbA1c. If HbA1c is at goal, then we may not increase it. If the patient is overweight, a good idea is to increase the dosage to 14 milligram and reduce another medicine patient may be taking. If patient is taking sulfonylurea, or patient is taking insulin, reduce that so that you are able to give 14 milligram without causing hypoglycemia, because this would be then more effective with multiple action. You know, this semaglutide is known for its various benefits, very robust glucose lowering effect, and then very good cardiovascular protection, and then renal protection, and lately it also has got liver protection that prevent fatty liver disease. So usually the 3, 7 and 14 milligram, and there's an alternate plan also, but we practice this 3, 7 and 14 milligram. So the side effects, because it's semaglutide, it is going to slow down gastric emptying, and it may cause nausea, it may cause vomiting, and the contraindications are the same as for injectable semaglutide: medullary carcinoma of the thyroid or MEN2. They are the contraindication, absolute contraindication, and history of such tumor, there is also contraindication. And if patient has suffered from pancreatitis, that is also contraindication. But if patient does not have that history, then we do try and watch for pancreatitis. GI side effects are very common, but because we start with a low dose and gradually increase, patient accepts. And when we explain the possible benefits, the potential benefits, then patient can tolerate this little nausea, or we can manage nausea with additional medication like domperidone. Because it has got some effects on the stomach emptying, so some drugs may not be absorbed as fast as they normally are. So they may delay absorption of drugs. Those drugs which have a very narrow therapeutic index, like warfarin, we want a very precise level of warfarin. So I think that case you have to monitor INR more frequently and then adjust the dose of warfarin accordingly. Similarly, thyroxine is also an extremely important drug, which also has a narrow therapeutic index. Plus, thyroxine is also given on empty stomach, but with the full glass of water. So if somebody has to be prescribed this semaglutide oral and thyroxine also, then the best, I think, sequence should be first patient takes semaglutide, oral semaglutide, and half an hour to 1 hour later, patient takes thyroxine with 1 glass of water, and 1 more hour, and then patient takes the rest of the medicines and the food or whatever. So the evidence in favor of semaglutide, there are 3 series of trials. One is Pioneer. This is Pioneer 1 to 10, and these are financially supported by the innovator, which is Novo Nordisk. But of course, the independent studies, they showed various aspects, efficacy and the safety, and its comparison with other established glucose-lowering therapies. SOUL was a cardiovascular outcome trial to see that the drug has got same benefits, cardiovascular benefit, which injectable semaglutide has. Oasis is study for a high dose semaglutide oral 25 or 50 to see its effect on weight, even in a non-diabetic patient. So I'm going to briefly give you the summaries of all these 3 series of trials. In Pioneer 1, evaluation of efficacy and safety, and this was given to healthy volunteers versus placebo. So it proved safe and effective. In Pioneer 2, it was compared with empagliflozin, full dose empagliflozin 25 milligram versus 7 or 14 milligram of semaglutide. And then Pioneer 3, where semaglutide was compared with sitagliptin. In this study, 7 to 14 milligram as tolerated, and as per the effect, the dose was given, and then patient was given sitagliptin full dose 100 milligram. Pioneer 4, they compared it with injectable liraglutide. Here the same dose up to 14 milligram. Here the dose was up to 1.8 milligram, which is the standard dose for diabetes. Liraglutide, when used for diabetes, the dosage is from 0.6 milligram to 1.2 milligram and then 1.8 milligram. We usually do not go beyond that unless we are treating obesity. For that, we can go up to 3 milligram. And in Pioneer 6, they did the safety trial, cardiovascular outcome trial, just to show that this oral semaglutide is also safe from cardiovascular point of view. So these are the Pioneer studies, 10 phase 3A global trials, multi-center trials, 1 to 10, evaluated oral semaglutide up to 14 milligram, because this is the dose for diabetes, compared with placebo, compared with empagliflozin, compared with sitagliptin, and compared with liraglutide, and broad type 2 diabetes patient, including those with CKD and with high risk patient. So in Pioneer 1, the results was 1 to 3. Pioneer 1, drug naive type 2 diabetic patient, that means newly diagnosed patient with type 2 diabetes. They were chosen and they were given the drug 7 to 14 milligram, and there was very, very robust HbA1c reduction. Look at this one, 1% to 1.3%, just with 14 milligram of the original name is Ribelsus, but we don't have that in Pakistan, but the other alternatives hopefully would have the same effect. And then there was weight reduction also, 2 to 4 kg, which we always love. In a diabetic patient, we always love a medicine which reduces weight also, because majority are overweight. In Pioneer 2 trial, empagliflozin was compared with HbA1 in Pioneer 2, when Pioneer 2, this oral semaglutide was compared with empagliflozin 25 milligram, and there was greater reduction with semaglutide as compared to empagliflozin 25 milligram. So there is 1.3% A1C reduction versus 0.9. So it is more potent than empagliflozin. empagliflozin is also a great drug, and we know it is a very, very effective drug. So I think it was more effective than empagliflozin. In Pioneer 3 trials, it was compared with sitagliptin, and again see HbA1c reduction was more with semaglutide as compared to sitagliptin. So all three established drugs, semaglutide oral was more effective. So this established and this provided the proof of concept that with this technology, semaglutide is absorbed and is effective. And then Pioneer 4 and 5 comparison with GLP-1 receptor agonist liraglutide, and also patient included was CKD. One beauty of this class of drug is that they are safe in CKD also. Even in CKD5, this drug can be given. In Pioneer 4, liraglutide versus placebo, non-inferiority study, and it proved that it is equivalent to, it is as safe as placebo. No cardiovascular adverse action. Sorry, in Pioneer 4, they studied cardiovascular safety. Semaglutide oral versus liraglutide subcutaneous. So both were equally safe. In Pioneer 5, moderate CKD patients were included with GFR of 30 to 59, and then again there was good HbA1c reduction of 1%. So in all studies, oral semaglutide was effective, and this trial, Pioneer 6, they studied the cardiovascular safety, double-blind, placebo-controlled CVOT trial. Population was type 2 diabetic patient with high cardiovascular risk, and results, there was MACE. The 3-point MACE means non-fatal myocardial infarction, non-fatal stroke, or cardiovascular death. And collectively, the composite of 3-point MACE, and see that there was cardiovascular safety was confirmed. Fewer cardiovascular deaths in patient on semaglutide. Conclusion, cardiovascular non-inferiority established. This trial did not have the power of proving superiority. For that, another trial was designed that I'm going to show you very soon. This is that trial, SOUL trials. In fact, this is also a series of trials. The objective was to assess cardiovascular safety and efficacy of oral semaglutide 14 mg in type 2 diabetic patient. Design phase 3, double-blind and placebo-controlled. The number was 9,650, a fairly big number, to draw a credible conclusion in type 2 diabetes patient with established atherosclerotic cardiovascular disease and or CKD. So these were high-risk patients, and that is the right group of patients where you want to study the cardiovascular safety. Mean follow-up of 49 months. So the primary endpoint was MACE. In both the groups, the MACE was counted, and the MACE I already explained: cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke. So the result was very encouraging. 12% MACE in semaglutide versus 13.8 MACE in placebo. What does that mean? That those 3-point problems, non-fatal MI, non-fatal stroke, or CV death, occurred in fewer patients on those who were on semaglutide. So this is cardiovascular. This not only means it is cardiovascular safe. That means, like injectable semaglutide, oral semaglutide also has benefits in preventing cardiovascular events. And hazard ratio 0.86. That means MACE was better than placebo. Conclusion, oral semaglutide significantly reduces major cardiovascular events in type 2 diabetes. This is particularly relevant and important because 70 to 80% morbidity and mortality in type 2 diabetes is related to atherosclerotic cardiovascular disease. So this drug not only controls glucose without causing hypo, but also helps reduce weight, plus it prevents cardiovascular complication, which is, I think, the ultimate aim of the treatment of diabetes. And then key takeaways from this study: oral semaglutide 14 mg reduces major cardiovascular events in type 2 diabetes. It expands therapeutic reach of GLP-1 receptor agonist to oral administration. I remember when I prescribe injectable semaglutide, I have to brief the patient. First of all, I have to explain to them that whatever they have heard from the social media, that is wrong. Then I have to highlight the good points. Then, of course, I have to demonstrate the method of injection, and the cost also is discussed. So this takes 7 or 8 minutes. But pill, if the same thing is available in the pill, we can just prescribe it like we prescribe metformin. And it is much cheaper, at least in Pakistan. Because in Pakistan, the original semaglutide oral is not yet available. It might become available, but it is not yet available in Pakistan. So the semaglutide oral, which is available in Pakistan, that is much cheaper than injectable original drug. So that would increase the reach of the drug. You know, in my opinion, not even 10% of people who actually need GLP-1 receptor agonists based on ADA and EASD guidelines, not even 10% are getting it. So one factor, the cost factor, and the other factor, needle factor, is taken away. So I guess more and more people will benefit from this great drug. Safety profile: main adverse effect, GI symptom, nausea, vomiting, diarrhea, which is the class effect of this drug. Low hypoglycemia risk unless used with sulfonyl urea and insulin. If you ever use semaglutide, whether oral or injectable, and patient is on sulfonyl urea or insulin, I think in anticipation you should reduce the dose of insulin or sulfonyl urea, or at least you should be vigilant that after starting semaglutide, patient may develop hypoglycemia. If that thing happens, then you don't blame semaglutide, you actually then reduce the dosage of sulfonyl urea and insulin. Patient would blame the semaglutide because he experiences hypoglycemia after this drug. So, but actually hypoglycemia is caused by sulfonyl urea or insulin, because then this effect was added on the effect of semaglutide. Safe in cardiovascular disease, even end-stage kidney disease, we can give semaglutide. So CV cardiovascular safety not only established, in fact, it has proven superiority. So great drug now available in oral form. Oral semaglutide, evidence from Oasis. This is actually the weight problem. You know, so far we have been talking about semaglutide for diabetes. Now, just like semaglutide, in higher dose, in 1.7 or 2.4 milligram, it is used, injectable semaglutide is used for weight problem. Similarly, there are studies to see if we can use oral semaglutide also for weight management, 25 milligram or 50 milligram. And this is so far not approved by FDA, but the studies are underway. I'm sure it will also be approved for this purpose soon. The results: Oasis 1, which was published in Lancet in 2023, mean weight loss with 15 to 25 milligram, from 25 to 50 milligram as tolerated, was significant, 15.1%. So weight loss of 15.1% in people who were on oral semaglutide versus just 2.4 milligram who were on placebo is a very good result. And the p-value, I think, means that it was a very significant finding. And more than 10% people, they had weight loss more than 85%. 85% of the individual had weight loss of more than 10%. Why 10%? It is important because we know that 10% weight loss gives us almost all the metabolic benefits. More loss will of course be better, but at least 10% loss mean the metabolic benefits we have achieved. Oasis 4 was published in New England Journal of Medicine in 2025, and here they use the same dosage, and the mean weight loss was here I think it is 25 milligram and 13.6% as compared to 2.2%. So with this dosage, which these strengths are not available in Pakistan, 25 and 50 milligram, when available we can use them for the management of obesity also against Wegovy, which is another injectable drug for weight loss. Clinical implication of Oasis: oral semaglutide 25 to 50 milligram achieves clinically meaningful weight loss. 10% or more is clinically meaningful. Comparable efficacy to injectable semaglutide 2.4 milligram. This 50 milligram oral is equivalent to 2.4 milligram injectable. Expected GLP-1 side effects related, I think they were there, but they were well tolerated, and there's potential oral alternative for obesity management also. So key takeaways: Oasis oral semaglutide 25 to 50 milligram induces robust and sustained weight loss in non-diabetic patients also. So the summary, ladies and gentlemen: first of all, oral semaglutide provides a convenient oral substitute of injectable semaglutide with all the benefits: atherosclerotic, cardiovascular, MACE benefits, kidney benefits, liver benefits, all of them, because once it is absorbed, it is just the same semaglutide which we inject. So with this snack technology, it became possible to avoid needle. To be effective, must be taken as discussed. First thing in the morning with a sip of water, and you do not swallow the tablet whole, and you do not take anything for at least 30 minutes, but preferably for 60 minutes. More effective in HbA1c and weight reduction compared to placebo, and it was also more effective compared to empagliflozin 25 mg, sitagliptin 100 mg, and liraglutide 1.8 mg. Slightly less effective than injectable semaglutide. Should increase the prescription to those who need a GLP-1 receptor agonist but has not been taken because of the cost factor or because of the needle phobia. Approval as a weight loss therapy is awaited. With that, I'd like to thank you for your patient listening. This has been Professor Aziz Rehman for Medurstand-Understanding Medicine. Thank you very much. I wish to see you in the next video also.